Hello, everybody. My name is Sadena Thevarajah, and I am Managing Director here at Health Begins. Today, I am joined by Victor Tabbush. Victor, would you like to introduce yourself?
Yes, Sadena, thank you very much. Good day to everyone. My name is Victor Tabbush. I'm an emeritus professor from the UCLA Anderson School of Management and a senior fellow at Health Begins. For the last 10 years, I've been working in the area of long-term services and supports with community-based organizations and health systems in order to bring about cross-sector partnerships and to make the business case for addressing the social determinants of health.
Thank you, Victor. Thanks for joining us today. We are so fortunate to have you share your presentation with us, and we're really fortunate to have you here at Health Begins as a senior fellow. Together, Victor and I would like to thank everybody on the line for joining us on this webinar on how to calculate risks and optimize rewards of upstream care. I have a few housekeeping notes. I wanted to mention that Rishi Manchanda sends his apologies. He had a family emergency come up this morning and he won't be able to join us. But I'll be taking over for the beginning of the presentation with most of it by Victor today. And before we start, I want you to know that the webinar will be recorded. We'll be sending this recording out to all registrants afterwards. All participant lines are on mute. So if you have a question for us, please go to the GoToWebinar doc and you can enter your questions at any time in the question box that appears there. We have reserved time at the end to go over questions, so please feel free to put them in at any time. If you have technical difficulties, you can also put that in there and we have a team that will be able to answer those. So the final note is that the presentation is scheduled to last for 1 hour. And with that, I am actually going to stop sharing my webcam so that you can have full access to the slides. And you should be able to see everything on screen now. So just at the beginning, I wanted to tell you a little bit about Health Begins. I'm just making sure these will advance. 1 second. Sorry. Okay, there we go. So about Health Begins, most likely if you're joining us, you know a little bit about us. We help clinical and community partners move upstream with expert coaching and facilitation, technical assistance and tools, and educational and quality improvement programs. If you did not reach this webinar through our listserv, I encourage you to sign up for it at healthbegins.org on the Contact Us page. And so you'll always be directly informed about our upcoming webinars and newsletters in the future. So I wanted to start off this webinar just giving you a little bit of background of how we came up with this idea for this February webinar. Last month, you may have joined my colleagues Sarah Bader and Rishi Manchanda as they reviewed our path to building upstream capability and impact. We use at Health Begins the get ready, get set, go upstream approach, and they walked everybody through that. If you would like access to that webinar, please email us at info@healthbegins.org and we can get you set up with access to that webinar. What they went through, and I won't spend too much time here talking about it, was our upstream readiness assessment as a first step for organizational readiness. It was focused on health systems. During that webinar, we have since built one for community-based organizations that we have been sending around. And so we have both at this point. After getting ready, the next step is to get set, where Health Begins can help teams identify a priority population, an upstream problem, find partners to work with, and data to move upstream. This webinar falls more closely in the get set category. And of course, the final moment is to go upstream with upstream QI. And we'll have future webinars to discuss that. So on the get ready component that was discussed last time, There was the Upstream Readiness Assessment, which is an online tool to identify strengths and areas for improvement. We went through 10 domains of readiness during that webinar, from the external environment, executive sponsorship, quality improvement, developing infrastructure. And one thing that we found from feedback from that assessment, as well as feedback from clients, and also my colleagues and I in the past month were able to attend the New York district event, which was really eye-opening and amazing to hear from community-based organizations there about some of their challenges. And a lot of it focused around financial readiness, which is when we thought we should present a webinar on this. We have an amazing senior fellow and Victor who would be able to present on this. And that's where we got the idea. The challenges that we were hearing specifically from CBOs was about valuing the services that they provide to the patient, especially in ways that the health system recognizes. They had challenges in predicting costs when they were providing the services, on representing the cost. So when it came time to contract with a health system or enter into negotiations or even broach the conversation, they didn't know how to represent those costs and benefits to the health system. That also made it challenging to advocate for their own organizational interests when it came time to partner. And of course, the formal agreement as a result became challenging as well. And so something that we're hoping that this webinar will help do is even the playing field. So as we know, the health systems in our country are maybe disproportionately resourced compared to the community-based organizations. So can we help transfer some of that capability to build up community partners as we're doing this upstream work? That's an underlying question that we have as we broach this topic. And so with that, I would like to turn it over to Victor to talk about how we can go about calculating financial risks and optimize the upstream rewards of care. Victor?
Thank you, Sadena. Certainly the time for cross-sector partnerships is propitious for a number of reasons. First of all, let's take a look at the social service sector. Now, what do I mean by that? I mean principally the community-based organizations that provide social services such as nutritional support, non-emergent transportation, even housing, and maybe even financial support. The capacity of these organizations to bring about reductions in medical utilization and therefore medical expense, has been well documented. There's just been a recent summary of the work of Elizabeth Bradley that may be known to you. 74 different studies were examined and found a fairly consistent set of value from social spending. A word or two about value. There are really two types of value in this context, where social service organizations come together with the medical sector to forge partnerships. There is the intrinsic value, meaning the benefits that accrue to the individuals that receive the integrated care in terms of an improved quality of life, improved well-being, an improved patient experience. But there's also instrumental value, and that will be really the subject for today's webinar. By intrinsic value, I mean something very different than I do mean from the term instrumental value. Instrumental value means the financial benefits that stem from the delivery of services based on these cross-sector partnerships. Principally, we are speaking about, when we talk about instrumental value, we're talking about the cost avoidance that stems from successful partnerships in this sphere. Cost avoidance and sometimes also revenue enhancements that accrue principally to the medical sector partnerships. Now, the medical sector, when I refer to that, I'm referring to organizations such as hospitals, IPAs, independent practice associations, ACOs, accountable care organizations, FQHCs, and even health plans. So the coming together in an integrated delivery system of the social service and the medical sector really stems from, and I've mentioned this, not only the potential, but the demonstrated evidence that social service organizations can have an impact on lowering medical utilization. And on the medical sector side, there is an increasingly strong set of incentives to bring about that lower medical utilization that the social service organizations can contribute to. And I'm referring now to some of the new payment models payment systems that have been introduced over the last several years. I'm talking about the Medicare Shared Savings Program, bundle payments for care improvement, patient-centered medical homes. That's been an emphasis for quite some time. The Hospital Readmission Reduction Program, Hospital Value-Based Purchasing Program, the Skilled Nursing Facility Value-Based Purchasing Program, MACRA, Accountable Health Communities Model. There's a lot going on in the way in which medical players are being paid for the services. But there's one characteristic in common. When we look at all of these innovations in payment reform, it's this. It's an increased responsibility that providers are assuming for the total cost of care. And with that comes a resulting stronger incentive, clearly, to reduce the total cost of care. And social service organizations can do that. And hence the the appropriateness now of these kinds of partnerships. Anytime a partnership is to be consummated, a partnership is to be arranged, there has to be a mutually advantageous relationship. Both sides have to benefit. And we're going to be looking at really the financial consequences in this webinar of an integrated system of care where social sector organizations come together with medical sector partners. And these financial consequences really come in two different shapes. The economic returns, the financial benefits, if you will. And secondly, the variability of these returns, which I'll refer to as risk. For the partnerships to work, there has to be a sharing of returns and risk from these partnerships, a sharing that is balanced, and a sharing that has to create the right kinds of incentives for furthering the goals of the alliance. Now, when I talk about return, financial return, I mean something quite specific. I mean the difference between value, that is the instrumental value stemming from the introduction of social services into the system of care, and the cost of providing these social services. So let this red dot represent the cost of delivering these community-based services, such as nutritional support, respite, and a whole array of potential interventions. And let the height of the green dot represent the value, meaning the extent of cost avoidance. And clearly the difference between the two, the height of the value and the height of the cost of delivering that value, would represent the return that stems from the integration. Now, that return needs to be distributed, and that's going to be dependent, that is, the sharing of the return is going to be dependent on the extent of the payment that is made to the CBO. And so if it's the level indicated by the purple dot, then the return to the CBO would be this bracketed amount, and the residual would be the return to the medical partner. And nothing is implied by the relative differences or the relative magnitudes of those returns. I'm just wanting to show how the total return will ultimately be divided. Now, in addition to return, there is going to be there's going to be risk. And risk stems from uncertainty. Uncertainty meaning that we don't know for sure what the results will be, what the returns will be from this partnership. And there really are two different types of risk. There's first of all what I might call performance risk, which means the value of the introduction of services delivered by the community-based organizations may not be as great as were expected. And that's, again, called performance risk. But there's another kind of risk as well, and that's cost risk, that the expense of delivering these ancillary services into a system of care may be actually higher than was anticipated. So those are the two types of risks that stem from uncertainty: performance risk and cost risk. Now, the way in which the returns and the risks are shared, and therefore the favorability of the partnership arrangement, is going to be dependent on the nature of the payment system that is used to compensate the social service organization. Now, I'm going to introduce to you, or I'm going to give you a categorization of what I think are 5 really exhaustive payment systems. And each one will have a different profile of risk and return and will create different incentives for the two partners. And some of these will appear somewhat novel. Some of them will be kind of old-fashioned. And I have not put into this categorization giving it away, that is, no charge whatsoever, in the belief that it is not a sustainable model for community-based organizations to rely on grants as the demands for their services rise from the health sector partners. So the first one, I call it cost recovery. And what does that mean? It's not all that common anymore. Conceptually, it exists. It means that whatever the expense is, or whatever the expense turns out to be for the community-based organization in providing services to the medical partner in an integrated system of care for, let's say, high need, high cost, high risk individuals, whatever those expenses turn out to be, the community-based organization gets fully reimbursed for them. Second one might be much more common, and maybe this is the most common form of reimbursement among these alternative payment systems for social services, and that's fee-for-service. Fee-for-service means that the fee is set, unlike under cost recovery, it's set prospectively at the beginning, prior to the service being delivered. And a fee is set for every unit of service. What is a unit of service? Well, in this context, a unit of service might be a ride to let's say, to a follow-on appointment to the primary care physician after discharge from the hospital. A unit of service might be a home-delivered meal. A unit of service might be a bed night in respite. So one could conceive of a payment system where the community-based organization gets reimbursed on a per service basis. Every meal that it provides, it gets a stipulated number of dollars. For every bed night, similarly, a certain number of dollars. The next one is that we might consider is a case-based system. And you can think really of this as a bundled payment system. It means that for each person that requires or is appropriate for a specific social service, let's say nutritional support, the CBO is provided a fee for a specific amount of time, and irrespective of the number of meals that might be required for that individual in that specified time period, that's what the community-based organization would get. And so clearly there's risk associated for the community-based organization. The risk here is if they accept a case rate, the service intensity, in other words, the number of units of service that will be delivered in that window, in that 30, 90, or 60-day window, might actually be a lot higher than they anticipated. But they take responsibility for that under a case rate system. The next one, and if you look at this array, and I realize it looks like the Winter Olympics here when I think about it. When you look at this array, you'll be seeing that as you go from left to right, there's increased risk being assumed by the community-based organization. Fee per person. This is a capitated system where the community-based organization would receive, under such a system, a fixed amount per high need, high cost, high risk beneficiary, and therefore would have the responsibility of providing whatever social services that individual might require, be it housing, be it nutritional support, be it transportation. And I might mention towards the end of the webinar, I'll be giving you a case study of a real organization that is actually operating under this system, working in conjunction with a hospital in providing a transitional service back into the community. And then finally, in this system, or in this array of potential payment systems, we might consider gain sharing. This is, I believe, a potentially beneficial from both sides system, has a lot of advantages and some disadvantages too. Under gain sharing, the CBO would receive a payment predicated on the actual value the service delivers. In other words, the extent of that cost avoidance or any promised revenue enhancements that are potential for the medical partner to receive. Now, many CBOs, in fact, most CBOs, are probably not in a position to be at full risk for the success of their programs, unless they have a lot of data that would allow them to have the confidence that the delivery of their services are going to create the kind of success that would lead to gain sharing. And so what gain sharing might involve really is a hybrid whereby the community-based organization receives some minimalist payment, maybe representing costs, plus a share in any financial return that is generated through the partnership. Now, looking at these 5 payment systems, I think it should be becoming clear that each of them divides risks differently among or between the two partners. Let's first of all take a look at the medical sector partner. Now, the number of the number of circles in each of these cells represents the degree to which the risk is being faced by that medical partner. So if there's only one circle, it means very minimal risk. And if there's 3, it means the maximum level of risk. So let's take a look at performance risk for the medical partner. Under all of the systems, except gain sharing, it is the medical partner alone that is at risk for performance. They, the medical partner, absorb all of the risk. If the social service does not succeed in accomplishing the cost avoidance and bringing about that instrumental value, well, that's on the medical partner. With gain sharing, however, that performance risk now is shared with the community-based organization. And so there's a significant difference there. Now let's take a look at the second column for the medical partner. This is the cost risk. Well, if the hospital or the IPA is paying the community-based organization on a cost recovery basis, then the medical partner is at full risk for expenses. If the cost of the social service is exorbitant, much more than anticipated, the only entity that is responsible for that is the medical partner. They have to pay up under that kind of a system because their memorandum of understanding has been based upon actual costs. It's been done, it's a retrospective payment system. Under fee-for-service, there is some cost risk that the medical partner faces. While the fee is stipulated, and there's no uncertainty with respect to that, as there is with respect to as there is with cost recovery, there is cost risk stemming from an uncertainty regarding the number of cases that are going to have to be taken care of, and the number of services per case. Under a fee-for-service system, if there's an excessive number of services per case or an excessive number of cases per person, then clearly the expenses to the medical partner are going to be higher than anticipated. But notice under capitation, there is no cost risk. The the medical partner is assuming no responsibility for costs. And so if the expense per service is higher, or if the number of services per case is higher, or if the number of cases per person is higher than anticipated, well, all of that responsibility for that excessive expense falls on the shoulders of the community-based partner. So let's move to the risk for the community-based partner. You can see that there's a flipping of the risk as we move from one payment system to the other. That when the medical partner has full cost risk, the community-based partner has no cost risk. And under fee-for-service, well, there is some cost risk for the community-based partner stemming from the possibility that one of those services costs more than the fee that has been agreed upon. Under a fee per case system, there is a little bit more risk that the community-based partner confronts, and that stems from the possibility that the number of services per case is a little higher than they anticipated. In other words, the service intensity, maybe the number of meals per month, is much higher than was anticipated. And under a fee per person system, well, the community-based organization is absorbing all of the cost risk. And so if the cost per service is higher, if the number of services per case are higher, if the number of cases per person are higher than might have been imagined at the outset of the signing of the memorandum of agreement, well, the CBO is absorbing all of that cost risk. Now let's go to gain sharing, and now you see that balance and that symmetry between the partners. Under gain sharing, the CBO partner is at some risk for excessive costs, because remember, they're receiving a portion of the net gain. And that net gain, that net return, is going to be a function of the expense of delivering these services. They're also at some degree of performance risk as well, because if the value of the service is lower, the utilization reductions brought about, let's say, by the inclusion of social services into the care plan doesn't really do what it was anticipated to do, well, the CBO partner bears some of that cost and some of that risk. One way to see this, at least let's take a look at the financial risk to the CBO under a fee per service system. If the cost is higher than was anticipated, it's very clear what happens. There's a lower return to the CBO. Now, with gain sharing, and this is another illustration of how one of these systems work, under gain sharing, we see initially how the system is set up. The anticipated value is given by the height of that green circle. the anticipated expense of the community-based service is the height of the red circle, and the payment to the CBO that is anticipated is at this level. But if the value turns out to be lower than anticipated, then the payment descends. And so there's a neatness about this system in that it aligns incentives and it puts the community-based partner on the same footing as so many medical organizations are being placed. And that is, they are going to be compensated on the basis of value, which is where all of medicine is going. So it should be clear from what I've said that risk is cost and performance risk are unavoidable consequences of putting together a cross-sector partnership. It's just a question of who bears that risk. And as we ascend from, or imagine moving from all the way to the left, cost recovery system through a fee-for-service system to a case-based system to a capitated system, as we move in that direction, there's less certainty and more risk for the CBO. But the flip side of that is, with that movement, means there's less certainty and more risk for the medical partner. I think I might actually have that as we go, there's more certainty, and the bottom caption is actually incorrect. As we move from left to right, there's less certainty and more risk for the CBO, but as we move in the other direction, well, that is correct. As we move in the other direction, the caption is correct. As we move down in the other direction, there's less certainty and more risk for the medical partner. So where is the sweet spot? Maybe it's a case rate system. I'm not quite sure that CBOs are willing to adopt a capitated system at this point. The absence of actuarial information, the absence of deep pockets in the event of outliers is going to be maybe a real impediment to that. But certainly we've got to get away from thinking about payments that are predicated on simply the costs per unit service. So let me pause for a minute and suggest that there is coming, and this is going to be made freely available to the community, anyone in this sector that has an interest in the social determinants of health and how they may be incorporated into a complex care management program for high need, high cost populations. There is going to be a calculator. It is a calculator, a return on investment calculator that the Commonwealth Fund in New York has funded. I actually was responsible for creating the calculator. And what it will do is a number of things. It will allow the partnership, and this is not strictly for a community-based organization. This tool is designed for a partnership. It's designed for a health system, an IPA that is combining with a community-based organization. And that partnership is looking to determine what are some of the alternative ways or payment systems that are mutually advantageous. They, I think, will benefit from a tool that will assess the returns to each of the partners and the risks of those returns not accruing under conditions of uncertainty. And all of this is done by looking at a series of payment systems. And so here's how the tool works. The users have the option of identifying 1, 2, or as many as 7 social services. Here's just a partial list. The user has the option of selecting a social service that is not one of the maybe core social services such as nutritional support, transportation, home modifications, or housing. you can use another category if you wish. So you begin by selecting the social services that you would like to see an assessment made of the impact that these services have when they're integrated with the traditional medical regimen. The next thing, or at least at some point in the calculator, the user is going to be presented with these five payment systems that I have mentioned. A cost recovery system where the CBO receives payments equal to its actual costs, fee for service where the CBO receives a payment prospectively for each service unit, something that is agreed upon at the signing of the memorandum of understanding, but prior to the actual delivery of the service and the knowledge of what that service unit cost. A case rate system where payments are provided to the CBO for a specified social service for a given period. In other words, nutritional support for 1 week after discharge from the hospital, for example. Or capitation, where the CBO receives a per member per month payment to provide an array of a prescribed array, not unlimited, but an array of social services that are specified. And the CBO receives a capitated rate and then becomes obliged to provide whatever social service, whatever service intensity, at whatever expense it cost under capitation. And then there's the gain sharing system, which I've mentioned, where the CBO receives a combination of a minimalist, let's say, fee for service, that payment, plus a share of the financial gains. And then what the tool does is calculate the returns. And it recalculates the returns for each of the payment systems for both the community-based organization, and these are expressed in a per member per month because the calculator asks how many members are going to be eligible for these social services. So there's a monthly net income per member per month under each of the systems, and the numbers presented here are a reflection of inputs that have actually been placed into an early version of the calculator. And the calculator also assesses the returns to the clinical partner in a per member per month basis, but also on a ROI basis, which is a very common metric, and it's a very good way to express the financial returns, that instrumental value that the clinical partner very often wishes to see expressed, reflected in a percentage format. I might mention that not only does the per member per month net income and the ROI for each of the partners depend upon the system, but it also, those metrics also will depend upon the levels of whatever the fee is. Is it 10%? Is the fee 10% over cost? Is the fee set at 20% over cost? Is the case rate established at a markup of 25%? And similarly for capitation, and similarly for gain sharing. The calculator allows the user to determine what percentage of the overall gain the CBO will receive. And under all of the other systems, the user has the option of selecting for each of the systems what the level of payment will be. So it's not just a question of what the payment method is, but also what the payment level is, because that will obviously also shape the ROI and the per member per month return. Another really useful feature of this calculator, which will be released towards now the end of March, is that it assesses risk, which I hope from today's webinar you realize is a very important dimension of these contractual arrangements. And the way the tool does this is to allow the user to conduct a simulation. So instead of putting into the calculator deterministic values, in other words, a single value for a key independent variable, you are allowed to place in to that for that value, you're allowed to place in a range a most likely number, a most pessimistic number, and maybe an aggressive number. An aggressive number meaning one that will lead to a higher return. And so with a range of inputs for all the key independent variables, the result is not a single ROI and a single distribution of those returns, but rather an array of ROIs. It could be anywhere from X% to Y%. And the return to the clinical partner shown here could be anywhere, as you see, from $295 per month to $340. And so it's going to be useful, I think, for the partners to recognize what the low end of the return might be and what the high end is, so that they can determine what an acceptable level of risk will be. All of these results clearly depend upon the user having data to populate the calculator. Key data that will be required will be obviously the expenses of the social services themselves, the fixed and variable expenses, and the impact that these are likely to have on utilization of all medical events. But the ones that are going to have the greatest influence on the returns will be those that are medical events stemming from acute episodes, admissions, readmissions, and emergency room visits. But there is also in the calculator an opportunity to assess utilization changes in pharmacy, imaging, rehab, skilled nursing facilities, length of stay for hospital admissions, and the service intensity of a day in the hospital. So let me just, in closing, present how the ROI tool can and actually is being used. And this is an example of an organization. It's an independent living center that is in the process of using the initial version, which has not yet been released, of the ROI tool in order to make a determination as to what it wants to do in presenting reimbursement options to a hospital with which it is in negotiations for offering a care transition service for patients to be discharged from that hospital. Now, this is a 60-day service, and it's been demonstrated in other contexts to reduce readmissions and emergency room visits, for which the hospital, under the current circumstances, has assumed financial responsibility. Now, what's interesting about this care transition service, it's really a portfolio of service, and that's important to note because it opens up the possibility of a capitated system. The service portfolio and what the Independent Living Center is planning to offer the hospital and what the hospital wants is a complete array of social services if they are appropriate for the patients that are designated for discharge, the highly complex ones that require a safety net in going back into the community. So the service portfolio is going to include nutritional support, transportation to follow on medical appointments, going to the pharmacy, picking up meds upon discharge, home modifications, if there are dangers that might create the greater probability of a fall and a resulting readmission. The CBO is responsible for the grab bars and the thresholds being lowered and so on. And also some basic home health nursing. And so the payment system options for the partnerships, one would be, well, we've talked about this, fee per individual service. So for every meal, for every ride, the CBO would receive a stipulated amount. And so the CBO under that system is absolved from all risk from case prevalence. In fact, if there are more cases, that is more individuals requiring a specific social service, and they're being paid on an individual service basis, a fee-for-service basis, they actually take in more revenues and they are better off. There's certainly no risk from prevalence. There's no risk for service intensity from a fee for individual service system. If an individual requires daily meals as opposed to one meal per day, no problem. The CBO can provide that, and its revenues will rise and its costs will rise, of course, but its revenues will rise to compensate for that. No risk and no performance risk under this system. If the nutritional support succeeds less well in keeping people out of a readmission status less well, the CBO is not on the hook for that under this system. The only risk that they face under this system is from service cost. If it costs more than $6 to provide the average meal, and they're banking on $6 being the service cost, well, they're at risk for that, and the hospital is not. Now, there's another system. There are several systems that we could consider. It could be a fee per person system, which is kind of a capitated system. Now, notice how very different that is, and the incentives are very different, and the risk profile for both the CBO and the medical partner. Under a fee per person system, a capitated system, the CBO has risk from case prevalence, that if more people need housing, supportive housing, it's going to have to come out of their pocket. That additional activity is not a revenue driver anymore, it's a cost driver. Same thing could be said about service intensity. If there's more meals per month for a particular case than was anticipated, that greater service intensity is going to mean a higher level of expense for the CBO, and it's going to come out of their revenues, and they're going to be at loss for that. There's a risk from service costs. If those individual services cost more than anticipated, they're out of luck. There is, however, under this system, no performance risk. And so while they may be delivering meals and getting paid for it, and if they're not delivering results, there's no punishment or there's no risk for that. Now, finally, and this is maybe worth looking at, especially if the CBO has been able to demonstrate to itself and others in the past that their services have been successful in keeping people out of the hospital in that critical 30 or 60-day window after discharge. Under a shared risk system, the CBO is at risk, partially at least, for all of its costs and for performance. And so wouldn't it be nice if the partnership, both parties could enter the calculator and place the numbers having to do with the expenses of these social services and the likely impact they would have on utilization, so that they could see what the respective returns and risks would be under these various payment systems. So that is the prepared presentation, and I do hope that there are questions. I'm sure that there will be, because I've gone through this rather technical material rather quickly. And so, Sadena, will it be you that refers questions to me?
That is correct. Thank you so much, Victor. This was incredible. And we already had a question asking about whether we'll be emailing everyone when your tool becomes available. And the answer to that is yes. We have a number of other questions that have popped up. So I just want to draw attention to the question box. As folks have questions, please insert them into that box. Something that excites me about the work that you've been doing here, Victor, is that we know that this will help start up conversations between CBOs and health systems as they're figuring out their partnerships. And this is a really useful tool to create that transparent relationship between them. So I am going to jump right into one of our questions from Kathy Coyne. And she asks whether the tool, does this not assume any other sources of payment to the CBO, such as the county, so housing, transportation, food? is all of the cost or payment expected to be assumed by the clinical partner?
Yeah, the tool assesses from an incremental basis. In other words, there may be funding coming into the CBO from the county. But what we're looking at in the calculator is the impact of this particular partnership on revenue, looking at the step up in revenue from kind of a baseline amount of revenue that might include revenue from other sources. Now, Kathy's question is a good one, because it may very well be the case that there could be incremental revenue. In other words, it could be a tripartite agreement with three partners. So there could be a step up in revenues from, let's say, a housing authority, as well as the reimbursement from the medical sector partner. And yeah, that I think can be. It's not something that the tool has been explicitly designed to do, but I'm going to think about that, Kathy, and see how one would adopt the tool, because we're really in just we're in the final phases, but adjustments can be made to think about maybe bringing in a third partner and looking at the incremental revenue there. So I really appreciate the question. It may very well result in a modification that's going to have a greater utility for other users. So thank you for that.
That's great. Thank you, Victor. I have a question from Michelle Jester asking, how do you convince payers and/or plans to agree to these payment systems with CBOs, especially when research or evidence may be scarce on the effectiveness and impact these non-clinical services have on health outcomes and healthcare costs?
So could you repeat the first part of that question? How do you
convince payers or plans? So when CBOs are engaging in these partnerships, that's how I'm reading this question. When they're starting these conversations, how do they make a convincing argument?
Well, look, to be absolutely convincing, you need proof. Mm-hmm. To have proof, you really need to have evidence from a controlled experiment with a control group and an experimental group. And you have to demonstrate that the experimental group has had significantly better results, the magnitude of which you present. Very seldom are you going to have proof. What you will probably have is evidence, a preponderance of evidence, enough programs of a similar variety that have demonstrated, maybe in different regions, maybe with slightly different populations, different demographics, maybe different leadership, programs similar to yours that have demonstrated really decent results. And so that preponderance of evidence may be sufficient. Now, what you can do when you're dealing with a situation like that, when you have you don't have definitive data, but you've got a range depending on which prior program you draw the evidence from, you can use the calculator's simulation feature, and you can place into the calculator a range of estimates based on other similar programs. And what the calculator will show you will be a range of ROIs. And sometimes the programs are so good that even on the low end, even if all the stars are misaligned, as it were, and all of the pessimistic independent variables go into the calculator, the result could very well be an ROI that gets above the threshold for what is required to convince a health system to buy the service. Mm-hmm. So in other words, the ROI could range anywhere from, let's say, 25% on the low end to 125% on the high end. Well, on the low end, it could be no less than 25%. And if the threshold for the health system to buy the service is for it to show a 20% return, well, your preponderance of evidence is going to be sufficient. Now, the third level, we have the 3 Ps. We've got proof, we've got a preponderance of evidence, and we've got plausibility. And sometimes you need to resort to plausibility. Now, what does that mean? It means we don't have any data. We have absolutely no data. But what we have is a population to whom this service is going to be delivered that is an extremely expensive group of individuals, maybe $60,000 a year, $5,000 per member per month, 4 ED visits per year, 3 hospitalizations, 2 readmissions, and on I go. The program that we may be proposing could have very limited expense associated with it, because you can do a lot with a little in care coordination and navigating people to social services. And so what one could do, and the calculator has a tool, a feature built into it, what you could show is the percentage reduction in, let's say, hospital admissions that must occur in order for the program to pay for itself. And sometimes that percentage reduction is so small, maybe it's only, we have to reduce hospital admissions only by 5%. The plausibility and intuition alone will carry the day and convince the health system, my heaven, if we do this, there's no way we can't get 5% of these admissions avoided. And so that's how I would go about it. Those three levels.
I think that's great. And I think what you said about plausibility and intuition going a long way is what we've seen in this space as well, where there might not be perfect evidence. So your tool combined with the 3-step process you outlined seemed to be enough to carry the day, as you mentioned. I have a question now from Dan Hackner, and his question's about startup cost versus maintenance cost. So he's run a program with a high starting cost, but incrementally lower marginal costs. So Victor, what's your take on setting service level thresholds to create cost reimbursement for different steps of costs?
Well, first of all, Dan, thank you. That's a fabulous question. And then that's one, I'll give you an example of where this was really, really important. And one of the reasons why I created the calculator, it is a social service organization here in Los Angeles that offered to provide and did provide care transitions to one of our academic medical centers, one of our premier institutions. The problem resulted from not the fee that was set, really, but rather the volume of these transitions that stem from the contract. Because of the existence of high fixed costs to set up the program and the paucity of care transitions that actually resulted, the per unit expense to the community-based organization of each transition was so high that it lost money on the contract. The volume was just not forthcoming. Now, the calculator recognizes that this can be a problem. And so what the calculator does is force you, when you're costing out your service, to specify what the fixed cost is and what the variable expense is. And when the simulation is run, if there's a high degree of, if there's a twin confluence of the following two things, a high level of fixed costs and a high degree of variability in volume, what you will find under a fee-for-service system, the CBO is going to be at considerable risk. And counterintuitively, that CBO will be at much less risk under a capitated system or under a case rate system if the services they are providing are very low in variable costs and are all of the fixed cost nature. So the calculator looks at, this is a really key question, and the calculator looks at that and will provide the results for you. Great question, Dan. Thank you.
Thank you so much, Victor. And we are actually right at time. We had many other great questions that came in, including how to value the cost savings to the medical partner, how can the CBO demonstrate that value. So I think what we'll do is we'll follow up via email to answer some of these questions. So I'd like everyone to keep an eye out for that email because I do want to be able to end in time. Thank you again, Victor, for presenting today. This was a great webinar, and thank you all for joining and for your great questions. As we mentioned earlier, we will be sending this out as a recording to all registrants. And as soon as you sign off today, a quick survey will pop up on your screen, and we'd appreciate it if you could take a minute to fill those out. just to let us know what you thought about this webinar and for future topics for our next monthly webinar. Thank you all, and hope you have a great day today. Thanks, Victor.
Thank you.